Okay, just ticked over to 7:32, so we might go ahead and get started. I'm Lane Carrandi. I am based at Monash University in Melbourne. I will be chairing today's session. I'd like to start by acknowledging the traditional custodians of the lands on which I'm coming in from today, which is the Wurundjeri people, and I pay my respects to elders past, present, and emerging, and pay my respects to any Aboriginal and Torres Strait Islander people joining us today. I'm sure many of you are aware of ImplementEcon, which is a network of people interested in research at the intersection of implementation science and health economics. So whether you're coming in as an implementation scientist or coming in as a health economist, maybe a trialist, maybe a health service researcher, wherever you might be coming in today, this network and this forum is really just about sharing ideas, sharing projects, learnings, and discussing different topics and applications for this field. So today we are joined by two excellent implementation scientists / health economists. I'll give a brief introduction, but you probably cited many of their papers and maybe you've seen them present at different conferences. So we have Thomasina Donovan, or Tommy, who will be presenting her CostIS tool, which is designed to guide researchers and practitioners through implementation costing. And then we'll hear from Clarke, who will be presenting some of her work about costing major system change. So I think the first webinar, for those who joined us, was really theoretical and foundational, and this webinar was really meant to be practical. So I might hand it over to Tommy to kick us off. She'll present for a bit and then have some time for questions afterwards. Thanks.
Thanks, Lane. All right, just getting presentation up here. Okay, so as Lane said, my name is Tommy. I'm a research fellow in health services research at a centre called the Australian Centre for Health Services Innovation, also called OSHI. This centre sits in a university, the Queensland University of Technology. So in my talk today, I'm going to outline briefly why it's important to cost implementation, and then talk about that tool I created called CostIS, which is really a data collection tool that guides costing of implementation, and specifically costing implementation strategies. I'll explain how the tool was developed, and then I'll demonstrate how I used it to cost the implementation of a particular study. The study I will talk about today is a hospital avoidance program in residential aged care homes. And finally, I'll wrap up with what I hope the implications of costing implementation are. So before I go on, I just want to acknowledge the other co-authors of this work on costing the implementation of this study, and acknowledgement of traditional owners of where this work was conducted, and that is the Turrbal and Yagara people of Meanjin, and Meanjin is another word for Brisbane. So firstly, let's start off with what is implementation science, which you might know, and implementation strategies, but I'm going to use an example to run through it. So let's say you've discovered a gene that detects cancer. Congrats, you're going to improve a lot of people's lives. But to put this knowledge into practice, you'll need to create a blood test so that we can actually detect the presence or absence of that gene. Amazing, but that's not quite it. Now you'll need to get the doctors to order the blood test so that their patients can actually receive this intervention. And this aspect here is where implementation science comes in. Implementation science uses methods to systematically promote the uptake of evidence-based interventions, so in this case, the blood test, into routine care. And these methods are called implementation strategies. In our gene example here, We could have an implementation strategy at the provider level. So we could increase doctors' awareness of the test through education. It could be at the practice or service level. We might want to change infrastructure, like ensuring the test can be ordered on their electronic systems, or we could do it at a system level by altering incentive structures. So in Australia, we might want to include it in the medical benefit scheme, and this could reduce barriers to access. So these implementation strategies require resourcing, which should really be accounted for. Appropriate funding of implementation leads to increased likelihood of implementation success. And unsuccessful implementation means we don't get to see the benefits of that intervention. And this is one reason why we should really cost implementation, so that we can appropriately fund it. Another reason why we should cost implementation is to ensure we're providing our decision makers with all the information regarding resource requirements for these new healthcare interventions. You know, at the moment we say, oh, this intervention is cost effective. If you invest this much resources, these are the benefits you'll see in the long run. But not always are we including the implementation costs in that evaluation. And so it is slightly unfair for the decision makers to be making decisions on implementing these programs when they don't know how much more resources are needed to put it in practice, and if that does offset the benefit that they're going to see in the long run. So now we know why we should be costing implementation, and is it currently being done? Or it's not often reported in the literature. And despite being one of the implementation outcomes, which we can see here, this is Proctor's framework for implementation outcomes, a commonly used framework by implementation scientists to choose what they should measure in evaluation. So despite being one of these key outcomes, it's not often reported in the literature. One reason for this may be due to a lack of methodological guidance in costing implementation. Currently, there are a few tools to assist costing implementation, and none of them are validated. And we can see this in the implementation outcome repository, which was created from a 2020 systematic review. The review went to find all validated instruments for each of those implementation outcomes. And when it came to cost, it could not find any validated instruments. So my supervisors in my PhD thought to put me right into this gap and to address it by incorporating knowledge from the health economics and implementation science fields, and really to bridge these fields in developing the costing implementation strategies tool, CostIS. So now I'm going to give you a brief overview of the development of CostIS, really just to demonstrate its rigor. So first of all, we did a systematic review. We wanted to identify what is currently being done in practice around methodologies to cost implementation. And what we found was implementation costs weren't often reported, and even when they were, the methods to cost implementation were very unclearly described. This systematic review had a limited scope. It was to digital health innovations and just one of those in particular. So then we thought, okay, well, we kind of know that people are likely costing implementation in practice, but perhaps they're just not reporting them in the scientific literature. So we went to key stakeholders that were likely costing implementation to really understand what their wants and needs were around costing implementation. These key stakeholders were implementation scientists, health economists, and some people in the health system. And so through semi-structured interviews and thematic analysis of that, we were able to understand their wants and needs, and then we developed a prototype at this stage. Then we took that prototype back to those same stakeholders. Some of them were the same, some had dropped off, and we got some new ones as well in this study. And we went and asked them, is this what you wanted and needed? And we did this through a modified eDelphi, which is electronic Delphi, to see how to get their responses back. And this was an iterative process. There was 2 rounds until we hit consensus that this tool was addressing their wants and needs. At this point, we wanted to preliminarily validate the tool. And so I applied it across 3 case studies in a collective case study to see how it is, how it's used in practice. And at this point, I did develop it a little bit more with the learnings that I got. And the QR code on this slide goes to a website where you can access CostAS and download it as you need. So I'll now show you the tool. The CostAS tool is an Excel worksheet made up of 3 templates in each sheet. And template 1 is really around the planning. So the example that I have here is just a worked example, and it shows through what you need to do. You need to list your strategy and then the activities and resources needed to operationalize that strategy. So if we go into audit and feedback, for example, we may want to meet with the stakeholders to identify what we're auditing and feeding back. And so that would be the activity, and those stakeholders in that meeting would be your resources. In template 2, this is where we capture any activity that's associated with implementation, and the key columns are around that activity, strategy, and resource, as well as how long were those meetings, if that's the example we're using, and what was the wage of those resources involved. Additional columns can be added for further analysis. So in here I have site, phase, and date. This allowed analysis around combining it by different sites or over time using the date, and you could really add or remove columns as you need them. So this template is very much based on time-driven activity-based costing and similar to activity logs as well. The last template is on valuation. So this is where you list each unique resource, and the majority of your resources in implementation will be labour. So they're at the top, and non-labour resources can be represented at the bottom. Here, I represent their salary, and then calculate the hourly rate and any on-cost if that's necessary to your project. So those are the 3 templates that make up the CostIS tool. And at this point, you'll have your implementation data collected in the tool, and to then analyze it, there's lots of different ways you could go about it. And I think it's really up to your analyst and what research questions you had at the beginning of the study. But here's some examples on how you could present the information. So in this figure, I have the 3 case studies that I did in that last study. And then I had organized this by implementation strategies. And these strategies are classified into ERIC clusters. ERIC is another implementation science framework that we use for terminology of all the different implementation strategies. So from this figure, I could infer that all of these case studies used a strategy in this cluster, which is provide interactive assistance, so around facilitating. And I could also infer that case study A only used a breadth of 2 strategies, whereas case study C used strategies across 4 different clusters breadths. And if that was my interest in the research question, I could get that from there. Another way to present it is by implementation resource. So you might do labour and non-labour. And as we can see, non-labour is here in the purple, and it's really a small portion of the resource associated with implementation. And in case study C, there wasn't even any labour at all. Okay, so now I'm going to move into how did I use CostIS in costing implementation of this study, which is the hospital avoidance program. When I did this implementation costing, it was part of a larger cost consequence analysis. So in the cost consequence analysis, we also had intervention costing as well as health service use and costs associated with that. So let me give you a little bit of background on the trial that this was on. It was a stepped wedge randomized cluster trial. It went for 58 weeks from March 2020 to May 2022, and that's important just to note that there were some COVID outbreaks at these residential aged care homes during this time. which was very difficult for the trial to run as intended. And then we aim to have 12 residential aged care facilities across the state of Queensland. And this is then listed here on the right in the map. And that's to note that the majority of them are in our metropolitan area in this bottom right corner, and a couple then are in more of a regional area. Okay, and now this video explains the study really nicely, so I'm going to play it for you. There should be sound. Okay, I might move on because I can see the comments coming through about some sound difficulties. Thank you for letting me know. Apologies for that. Luckily, I'm going to explain the trial components anyway, so that's okay. So to summarize what the trial was about, it has these 4 key components that would sit within the residential aged care homes. So first, we have specialised diagnostic equipment. So the trial provided these homes with this equipment, for example, a bladder scanner, so that they could identify UTIs on site. They also provided education and training to the personal care workers so that they could identify deterioration in their patients. And they provided these decision support tools, which were paper-based, that went on their lanyards to help them decide, does this patient need to go to the hospital or not? Finally, they had an implementation facilitator on site to help with the uptake of the components of this trial. For costing this trial, we decided to, we split it like this. We said these 3 components were the intervention, and this implementation facilitator was the implementation side. So this is what I costed for the implementation. And although this looks rather simple, this was definitely one of the hardest parts when costing implementation, is knowing what's intervention and what's implementation. So although this may look simple, this is definitely a challenging aspect. So what does that mean? It means that for the intervention costing, we included the costs around equipment and consumables, training, and any other additional consumables. For implementation, it was that ongoing facilitation, and there was an initial context assessment. And then we had health service use and costs, and just for interest, there was ED transfers by data linkage of the RAC home, as well as with our hospital data. And then the costs were around those ambulance transfers, ED presentations, and hospital admissions. So I said I'll just focus on implementation costing here. So how did I do that? I used my CostIS tool, and the data sources that I found my data in were around field notes, meeting minutes, activity logs that were kept by the project manager as their project management, I guess diaries, and the internal facilitator check-in forms, which was when the internal facilitator would meet with our research university-based team to make sure everything was going well and to see what implementation activities they were doing. What were the costs? I classify them as labour and non-labour. The labour was around those context assessments and ongoing facilitation efforts. I valued this using publicly available salary rates. And then for non-labour, we had these clinical facilitator packs, which were like printed educational materials, pens, paper, laptop and laptop bag. And there was some travel involved when facilitating. And I valued this at purchase price. For analysis, I descriptively analysed it at the residential aged care home level, and then I mapped it back to that ERIC framework that I mentioned, which is a terminology framework for the implementation strategies. So what did we find? This is the results from the implementation costing, and just to go through it, we found that the average cost per site for implementation related activities was about $9,500 Australian dollars, I think 2023 or 2024. And labour resources accounted for 85%, which we weren't surprised about, and 65% of this was the internal facilitator, because this was our main implementation activity. I then also organised it by implementation strategy and activity, and we can see, unsurprisingly, that facilitation made up 87% and context assessment was the remaining 13%. In this figure, I find a few interesting things I'd like to talk through. So first of all, this figure shows the implementation costs by residential aged care homes and study phases, and costs are presented in a weekly average across the phases to account for the varying duration of those phases for each site. So the first result I'd like to highlight here is the pre-intervention phase. We can see this reduce as the trial goes on, and that likely reflects a learning curve of the study team to increase efficiencies of establishing necessary processes over time. The next thing I find interesting is in this intervention introduction phase, which was a 4-week phase to introduce the trial to each site. And it varied widely from like $87 in home 10 up to $643 in home 1. And we'll talk a bit more about that next. But also to highlight that in the intervention exposure phase, we were still seeing a lot of implementation costs come through, which is not really surprising because this is where the internal facilitator would be helping, but just to make note of that at the moment. So from these results, what are the insights and findings that we can get from it? Well, if we think back to that variation, the fact that we saw this variation in both the extent and also the timing really actually reflected the levels of engagement each site had with the program. And so when I presented the implementation costs back to the other part of the team that did a process evaluation on this trial, they noticed a very similar difference across the fidelity of the program and the sites. And we were actually able to show that the sites that had high costs also had high fidelity, which was really showing that they were doing the implementation activity of facilitating, and that's how I was able to cost that. So I think it's nice to see that implementation cost doesn't also have this impact of showing what resources we need, but it also shows how it could be a measure of success of implementation. The next finding is around the fact that we had implementation costs extend well beyond the implementation phase into that intervention phase. And this finding is important because it really challenges that common assumption we have adopted in economic evaluations that suggest implementation costs are an upfront expense that can be ignored when we're considering those ongoing cost implications. And rather, these findings really highlight the need to understand and account for implementation costs because they do relate to ensuring the longer-term sustainability of these interventions in practice. And studies are without limitations. One in this one was that difficulty of separating implementation costs from intervention and research-related costs. And as well, I depended on existing documentation in this particular study. So there could have been key data puts unavailable, and at times there was aggregated documentation. So using COST-AS prospectively is something that we're putting into practice now and could overcome some of these limitations. So to end on what the implications of costing implementation, I think could be, I hope that it increases the reporting in the literature so we can do some, analysis across studies. I hope that it allows for appropriate resourcing for implementation strategies to increase implementation success. And I hope that economic evaluations of healthcare account for that full extent of costs, not the intervention and the implementation, so that we can give reliable information to our decision makers. And then we could be doing cost effectiveness analysis on implementation strategies as well. So which ones are best in what settings? Yeah. Thank you. I'll leave it there. Thanks, Lane.
Thanks so much, Tommy. There's just 2 questions, maybe. We have time for a bit. We'll start with an easy one. Why did you consider hourly wage plus 25%?
Yeah, so hourly wage plus 25% was the on cost of our institution. So when I find hourly wages online, it gives like the take home, I guess, well, not quite the take home, there's also tax, but the dollar that goes to the person, and it doesn't incorporate those costs that the organization has to bear for employing that person. So that could be around like leave and other things that don't come to mind now.
Great. And then I might put 2 questions together. So someone was asking, why did you classify training under intervention rather than implementation? And then another person said, can you delve in a little bit on how you decide what's the intervention and what's the implementation cost? So maybe you could share a bit more about the process that you took to define what the implementation strategies were versus the intervention.
Yes, definitely can. It's a great question, and probably why I chose this study as well, because education and training is like a classic implementation strategy. But for this trial, we felt it was within the intervention. And what helped us consider that is we consider implementation activities to be supportive, but not critical to the intervention. And so we want the intervention to be able to function as planned without the implementation activities. So for this particular trial, we were getting personal care workers to identify if their patient, the people in their residential aged care homes were deteriorating. And we could not assume that they knew what deterioration looked like. They didn't have clinical training through how they got their job. So we had to upskill them in knowing with that knowledge. And so that's why it was part of the intervention itself. I think that was the first one. I think maybe another point around splitting between implementation costs and research costs. That's another hard area to look at. And we find if we consider what activities would be required to be repeated if another site wanted to implement this, and that could help you differentiate between if it's a research cost or not. Yeah.
Great. Thanks so much, Tommy. Really appreciate it. And yeah, as you can see, her contact details are below. She's also in the ImplementEcon group on LinkedIn, so you can probably find her on there. So we might move to Caroline Clarke's presentation.
Hello, I'm here. Sorry, I was just opening the window. Hello, okay. I will share my screen. Thank you. There, can you see that?
Yes, looks great.
Perfect. Thank you very much. Brilliant. Hello, everybody. Thanks very much for joining today. So my name's Clarke and I'm a health economist and I work mostly on clinical trials. I'm based in London in the UK. I do a lot of work for different trial groups, different disease areas, so a lot of randomized controlled trials, a lot of service evaluations, various different things. So I'm going to talk to you today about multiple perspectives and requirements and how you might consider implementation costs within health economic evaluation. So here we are. So here's an overview of the talk. So I'm going to talk about multiple perspectives that we need for different decision questions that we would address using the same data. I'm going to give an example, a case study from the Respect 21 Mixed Methods Programme grant, which is around a framework that we produced for trying to cost implementation of a major system change. Then I'll talk about another couple of studies. So these are REFINE is a randomized controlled trial and PRIME is a within patient diagnostic study. And they sit in a different place on the implementation spectrum. And then we'll have a look at when do you need to do work around implementation costs and when not. And we'll have some conclusions at the end. Health economic analysis often does need multiple perspectives. So there was a question, I think, in the chat earlier. So this might help partially address that, I think. So quite often in the UK, we are thinking about what NICE wants, so the National Institute for Health and Care Excellence, and that's the body that decides what should become available for use in the National Health Service. So they tend to use incremental cost per quality adjusted life year gained, that's per QALY gained, and they look at things from a national perspective. But that's a different question from what might an individual hospital or individual health trust implement. So they might be interested in budget impact analysis or around process outcomes rather than cost per QALY, because often there is no extra budget. So having an incremental cost per QALY gained is not helpful. They actually just need to know, can they implement something that will reduce waiting times, for example, without having a cost increase. Most of my work is publicly funded by government funding or other sort of charity funded work. And we often have different intended audiences. So we might have something where we want to produce information that NICE can use to update clinical guidelines, or there might be something that's a more local decision to be made. And we would need to do this using all of the data that we have from the trial or from the study. So in order to work out what we're doing and how we're doing it, there's lots of engagement with knowledge holders and interested parties during the planning stages. So we would do this to help us define the care pathway for the patients and think about how implementation fits in. So we don't make such a strong distinction between what's the intervention and what's the implementation, because it all costs time and money. So regardless of how you split it, it still needs to be thought about. And we think about it in terms of cost perspectives. So health economists like thinking about the perspective. Who's paying? Is it the National Health Service? Is it a local hospital? Is it patient out-of-pocket costs, for example? So we would think about it in terms of perspective. So who pays? When would they need to pay? And that's how we would think about the sort of split between intervention and implementation. So this, requires lots of communication with the team to work out what's going on. So the health economist would be involved from the beginning in order to facilitate this. So this is a case study. The QR codes are a couple of papers, the protocol paper and the final report to funder. So this is on a major system change, a service reorganisation, which happened in part of London, so North Central, North East London and West Essex, which is just next to those two places. And they were reorganising how some specialist cancer surgery services were delivered. So they wanted to specialise because there's some evidence to show that this improved patient outcomes. So the clinicians were driving this, They wanted to make the change, and we were lucky enough to be in there collecting data to analyse how well it was going from the start. So that was very useful. So this is quite rare in a service evaluation, that the analysts, in my experience at least, that the analysts are involved from the beginning, so we could capture data. The qualitative team went to the meeting, so it looked very much like Tommy's tool in terms of going along to meetings and capturing information on how things had happened. So it's a mixed method study. We had a qualitative team, quantitative team. My part was looking at the cost and cost effectiveness of the changes, and that's what we're looking at here. So again, a couple of QR codes for papers. So the first one is cost utility analysis. So we were looking at the incremental extra incremental cost per QALY gained, and we used routine electronic health record data for that, and a difference in differences approach. So this obviously wasn't anything, nothing was randomised. The change just happened. So we had before and after the change, and we had London where the change happened, and rest of England. So that was the basis of our difference in differences approach. And I'm not going to say anything else about the cost utility analysis. The cost of implementation we included in the intervention arm. So London after the changes. So the cost of implementation went into the London after the changes section of the difference in differences approach. And to work it out, we identified key reconfiguration stages and expenditures. So we collaborated with the qualitative team who are going to the meetings that were planning these changes. We talked to patients, patient representatives, managers within the health service, finance teams at hospitals that were doing the changes, and clinicians at various different levels and places. We did a bottom-up costing, so exactly as Tommy described. It would have been very helpful to have had that tool sort of 8 years ago while we were doing this. So we identified the items, we applied unit costs based on salaries, and we added it all up. That's basically it. So the costs were, the implementation was happening. It took 4 years, and the changes were implemented by April 2016. So this is the framework that we put together as a result of doing all this work. We were sort of documenting what we were doing and how we were doing it to try and produce something that might be useful to other researchers in the future to try and show how you might go about doing this. So the items, the blue items on the left there, so we've got options appraisal, bidding process, and external review process. Then the next, so that's looking at developing business cases, scoping, doing travel analyses by external consultants, that sort of thing. And also the hospitals getting their bids together to bid for the service. Then we looked at stakeholder engagement and getting buy-in. So there were lots of events that the clinical staff ran to communicate with patients and to communicate with other clinical staff and other staff at the sites. There were lots of meetings, lots and lots of meetings, lots and lots of people. So yes, labour costs certainly a big part of it. So these we got from meeting minutes, information on how long was the meeting and so forth. Then making the change itself. So because of the type of change it was, a couple of the sites had to buy very expensive new surgical robots to do prostatectomies and nephrectomies. So that was a big cost. And then more meetings for planning, implementing audit systems, or collecting data for monitoring performance. And then the second half of the framework is more about sort of contextual factors rather than specific sort of items. So it's possible in this kind of change that there might be changes in the payments or billing. So in the UK system, or in the English system, hospitals provide a service and then they report it through secondary uses services. Is that what the SUS stands for? Never remember. And then they get paid for the services that they've provided according to the tariffs. So if a hospital is providing a different or new service, or if a new service is invented that the hospital then provides, then there might be a change around how the tariffs work. There could be a financial cost to patients. Maybe there's different out-of-pocket costs, different levels of time off work. So that's something we didn't include in this study because it wasn't a big consideration, and we had no data on it because we were using electronic health records. We didn't have any contact with the patients who were having the surgeries. Then the next thing to think about is the patient population. So this could change according to your whatever the intervention is. In this case, major system change. So as services change, the patients who take them up could change. So again, that can come from records, and the lifetime of the changes. So this is a sort of accounting question. So how often is change likely to happen, and what sort of depreciation do you apply to the machinery and this sort of thing? So the sort of headline results are these. So the robot costs were the biggest by quite a long way. That only applied to 2 of the sites, actually, not all of the sites, because that was only relevant for prostate, bladder and renal. Then the consultancy fee, so that was external consultants providing information back at the beginning. So when they were working through what changes to make, how to make the changes. 15% on staff time, so that's all the meetings that happened, and then other costs are just a smaller percentage. And we worked out per patient numbers to go into the cost utility analysis model on the basis of annual incidence of each cancer. So we're looking at prostate, bladder, renal and esophagogastric cancer. Okey-dokey. So a summary of that part of the study around the implementation costs. So there was no counterfactual. So we only had the cost of doing that change. We didn't have any other information on any other changes that may or may not have happened at the same time. And there were some, but we didn't have that sort of detail on what had happened elsewhere. There were other system-wide changes, there were national changes around integrated care boards that happened around a similar time. And we didn't manage to include much on that. It wasn't a clean time period, so you could argue really for prostate, the work started 10 years previously, but it didn't really begin in earnest until 2012, when the London Cancer Board was set up to start the work. There are a couple of things that appeared later on. So yeah, slightly messy time period. It was very difficult to get all the data. It was quite complicated. It was quite messy. There were other changes of using other cancers. There was also cardiac work that was rearranged at the same time. So 2 of the hospitals did a swap actually for some of their space and theatres. And so a lot of the meetings covered both things. So we had to try and attribute costs according to some fraction. So yeah, there were limitations around how we did it. The other conclusions and implications. So it was the first time that we used this kind of framework for this kind of analysis. We discovered that it was incredibly helpful to have the health economists involved from the very beginning and in good contact with the qualitative team. So we had regular team meetings and everybody was very involved. Oh, I've been speaking too quickly, I'm running out of breath. It is possible that including implementation costs in cost effectiveness analysis might make the intervention appear less cost effective, but that's not a reason to not do it. It just means presenting the costs in terms of perspectives so that different decision makers can see which costs are relevant to them. And it's incredibly important to have a mix of voices and specialties and methodological backgrounds and so forth to get the full picture of what's going on. And that's not unique to this project, that's for all health research. So how am I doing for time? Okay, so this is there's only one slide on the PRIME study, so we're getting there. So this was a within patient diagnostic study where all men suspected of prostate cancer were given a multiparametric MRI, where you have 3 different types of experiment done. And then, but if you only look at 2 of the results, then you have biparametric MRI. So everybody had 3 scans, the 3 experiments, and they did a thought experiment to say, well, if they'd only had the biparametric MRI, what would the diagnosis be? And if they had the multiparametric MRI, what would the diagnosis be? So that was the split that the multidisciplinary team, the MDT, looked at to try and work out the difference in consequences and pathway costs according to whether men had the biparametric or the multiparametric. So it's a thought experiment. So for this one, the implementation would have been actually switching from the multiparametric to the shorter, easier, cheaper biparametric. So it's a sort of de-implementation, if you like. But then there's questions around if you do move to a shorter MRI scan, can you actually rebook the time and use it? Also, does it change the setting where you can give the scan? Because if you don't need the third experiment, then you don't need the extra healthcare professional to deal with the contrast agent. Yeah, sorry. So the third experiment is giving an intravenous contrast agent, which some people are allergic to. So you do have to have another specialist around. So we've created a decision model, and that's almost ready. So the clinical results are out. The QR code is the clinical results, and the health economics is on the way. So the REFINE study, this is a randomized controlled trial. This actually, again, this is a de-implementation. So this is looking at patients who have advanced renal cancer, and after they've had an initial few cycles of IPI and Nivo, then they can either carry on with a standard Nivo given every 4 weeks by infusion, or they can do that every other time, so only every 8 weeks. So you're actually reducing the dose by half. So, and the thought is that it shouldn't actually make any difference, because anecdotally it doesn't make a difference. So for this case, there's nothing that you need to do around implementation. So we did still have the conversations around, do we need to think about implementation? But the answer was no, not really, because it doesn't really mean any change. So then, when do we need to think about implementation? So the context is really important. Who are the knowledge holders and who are the interested parties? And it involves lots of conversations of speaking to all of these different groups. So clinicians, other health service staff, administrators, finance team, care facilitators, patients, carers, public, policymakers, other decision makers. Everybody here has some kind of interest in the results and how they would then use them. It's really important to think about where does the intervention sit in the patient pathway. If you're trialling an intervention and then afterwards you discover it can't be implemented, then it's wasted time and effort. So the implementation question has to be considered whilst you're planning the new intervention itself. We need to think about who will pay for the implementation. So again, we come back to perspective here. Is it a national question? Is it a local question? Is it patients? Who is actually paying in terms of time or money, and who would decide whether the intervention gets into practice or not? And this is again at sort of different levels. So at the system level, is it available? Then at the hospital and clinic level, will people use it? Will the doctors order the blood test? And in the room with the patient, so how is that decision made? So we have to think very carefully about the audience. So this is always true for any analysis. We have to think carefully about the audience. What do we expect to change if our new thing does work? Who will need to issue guidance or change their behaviour in order to get it into practice on the basis of the work that we've done? So the framework that I've presented was designed around major system change, but it can be used more widely. So I just wanted to highlight here, we have various checklists for all the various checklists for things. This is the original in terms of health economics. It's the Drummond 10-point checklist, first developed nearly 30 years ago. It made me feel very old thinking about that. And it does cover implementation. It's slightly ahead of its time, perhaps. So these are just a couple of snippets out from the full checklist. It says 10 points, but there's a load of points because they've all got sub-points. So it does ask, were all the important and relevant costs and consequences identified? Was the range wide enough? Did it cover all relevant viewpoints? It asks about capital costs, so that would be buying the robots, for example. Have we thought about all issues of consent to users? And then the very, very last sub point of item number 10, did this study discuss issues of implementation? So this is in there. So the Drummond is trying to cover this. And then finally, some discussion and conclusion points. So the implementation spectrum ranges from drugs that can slot easily into the clinical pathway. So I'm thinking of the REFINE study there, where all we're doing is asking patients to attend less frequently, to complex interventions or service changes that substantially alter patient and staff behaviour and processes. And I think one of the issues why we've ended up with this divide, where economic evaluation doesn't always include implementation, is because health technology assessment historically focuses on pharmaceuticals, because that's the expensive and difficult thing that we have HTA for, and that they don't usually have a big implementation question. But we now have stronger assessment of complex interventions, diagnostics and service delivery changes. And they're relative newcomers for cost effectiveness evaluation, and they can carry a much heavier implementation burden. So yes, to say again, if the pathway is not fully explored, then we can miss implementation issues, and the analysis that we do might not address the actual question. So in order to try and resolve this, early engagement by the whole study team, including the health economist, with everybody else around getting the thing into practice, is really important. Yes, so that's it from me, I think. These are all the people involved with the different trials, and that's it. Thank you. Shall I stop sharing?
Sure. Yeah, thanks so much. That's great. Yeah, feel free to take a moment. There was a few questions in the chat, so maybe we've got time for a few. The first one is, can you elaborate on how you use the difference in difference analysis within the cost utility analysis?
Yeah, sure. So we got linked electronic health records, which covered people attending hospital, so secondary care and hospital, outpatient, inpatient, emergency care. That was linked with mortality data and linked with cancer registry data. So we had various bits on their cancer issues. So we looked at, for example, in the prostate group, we looked at everybody who had been diagnosed with prostate cancer over a 10-year period. I can't remember exactly how long it was. And we looked at those people, and we split them into being within the London area, so Northeast London, East London and West Essex, or rest of England, but ignoring the rest of London in case it was messy. And we compared those two, but we also compared before and after the change. So you have 4 groups. You have rest of England before, rest of England after, London before, London after. And it's a regression analysis to look and see what's the impact of the change. Does that help at all?
Yes, that's great. Does a lack of implementation cost framework affect the accurate estimation of the total costs? Probably.
It's quite difficult to get all the costs together. It's quite messy. It's hard to focus and hard to know. I mean, it's endless in some ways. You could spend your entire life doing one implementation cost analysis because there's so many different bits to look at. So if you've got a framework, it helps you to think, what's important here? What do I need to capture? Yeah, even with the framework, I think it's still very difficult to get an accurate estimation. But using it at least gives you something to. It helps actually with talking to the different people. So when I went to talk to the finance teams, I took a draft of the framework and I was like, here's the stuff we're looking at. What have you got that fits in these things that I don't know exists? So that was quite helpful.
One more question in the chat, and then maybe, Carlos, you can ask your question next. Interesting point on how costing implementation appropriately could make an intervention look less cost effective? Do funders need to start recommending or mandating inclusion of implementation costs to level a playing field?
I think funders should be looking at the analysis and saying, have you considered implementation? Because if it's not in there, it's partial, it's incomplete. It has to be in there. And I think I certainly feel that because HTA focuses so much on drugs, people forget how complicated it is to implement things and how much it can cost. The tricky thing is, it might be that you're approving something nationally, but the costs fall locally. So you've got two different places bearing the costs. So maybe at the national level, they don't care because they don't have to pay for it. But they should care because it's part of the analysis. So we would always try and present it as in such a way that you can choose your perspective and choose what's relevant to each decision maker. But yeah, I think it would be helpful if there was driving forces from the funders and from the approving bodies to ask people to include it.
Carlos?
Just a question for both of them. In terms of separating the implementation from the treatment, I think both of you have agreed in cost of implementation are not measured nor taken into account. But what is the benefits and probably when is good to separate one from the other, although you can combine later. And one, as you said, Caroline, maybe there's no point on doing that.
I think it helps to think about it and to classify it. But ultimately, in my mind, it's about the perspective. I think this shows that I'm a health economist and Tommy's an implementation scientist. So we're doing the same thing and we're calling it slightly different things, but it's the same idea, I think.
Yeah, I agree. I think health economists have a great grasp on this whole perspective thing, and I think that is where it really comes into it. So I really liked your point, Caroline, on what are the costs in practice? Like, yeah, the costs overall to the national body might not be. It will look probably cost effective to the national body, but for this service, introducing a new guideline, what does that actually look like on the ground? And is that outweighing the benefits of what's going to come in from doing that? Yeah.
Can I maybe mention also, it's depending on the perspective. If, for instance, a local authority knows that HIV testing is fine, they want to implement, but they want evidence of the implementation effectiveness, then is when actually maybe it's good to separate them, when they want really to understand if the implementation strategy increase or not uptake, maybe.
Okay, so if implementation has been successful, like if there's been increased adoption or in that rate, or the benefits of the intervention there still.
So when the answer that they want to know is, has this implementation strategy increased the uptake of a certain treatment? So you really need to put a cost to that, increase uptake or decrease uptake. That is when probably I see more on the distinction between one and the other being more useful. But when you want the causal pathways of, does this implementation strategy increase or not increase the number of people receiving the treatment?
Yeah, okay, yes, I see now. Yeah.
All right, I'm going to have to wrap it up. I'm conscious that, everyone in the Southern Hemisphere needs to have dinner and go to sleep, and in the Northern Hemisphere, you might be starting your day. So thank you, everyone, for coming. Thank you to the presenters for the incredible knowledge that you've shared today. Just a heads up, please join us on the LinkedIn group. We'll have a webinar in the first half of the year, so be on the lookout for that. There will be a recording which will be sent to everyone registered, and we also have the first webinar. We'll include a link to the first webinar recording as well. So thank you, everyone, and have a great rest of your day.